Debabrata Padhy, Dr. Neeraj Agarwal, Dr. Rajeev Sharma, Dr. Kunal K.K. Pal, Dr. Rakesh Rajput himself, John Mukhopadhyay, and Ramesh Sen, whom I don't see as yet, but I believe would join. I am going to share something that few of you know and many may not, and I'm taking the opportunity. So I take you back to the first half of 1994. There is a small group of surgeons who meet in New Delhi. It's in a small room, and the surgeons include Professor Prithpal Singh Maini, whom we just lost, Professor Nagi, Professor Nandulal, Professor P.V. Mohandas, four big names. Professor K.T. Dholakia, who's there in absentia, but about to come in. And because they are short of people, they call in a gentleman who's a young, upcoming gun in arthroplasty at that time, called Dr. Pichayanand Ramachandra Suryanarayan. And they don't find anybody else, so they pull in one guy and say that, come in, we're going to start and found an organization called the Indian Arthroplasty Association. That one person called into that room to make it an odd number of people, and who was made the founding member of the Indian Arthroplasty Association, unfortunately, was destined not to make unhappy people very happy like you guys, but was destined to make unhappy people less unhappy for some time. That seventh person in the room is yours truly. And I must share with you that I was a founding member of the Indian Arthroplasty Association. आज मुझे शर्म आती है कि मैं arthroplasty नहीं करता, ना मुझे आती है वो करनी. लेकिन I wish all of you luck. And I hope that you will continue to make unhappy patients very happy, which is what all of you all do, and leave those unhappy patients to be made less unhappy for some time for people like us. So all the best. Please continue with your teaching ventures. And I know that the IAA has come a long way since that small room discussion in New Delhi, where I told you the big names who were there together. And I happened to be that young kid on the block who was there, जो एक आध arthroplasty की fellowship करके आ गया था France से, so he thought he was an arthroplasty surgeon. He was confused because he used to do trauma. Somewhere in between, he got derailed and became a spine surgeon. So thank you guys for inviting me. Keep the fire burning and spread the knowledge all over. With and have a great time. Thank you so much.
Thanks, Ram. It's difficult to follow you always, but I actually echo your sentiments. It's a great pleasure and honor for us in the IAA to actually have a joint webinar with the IAA, with the IOA, and which happens to be our parent body anyway. And your anecdote was really extremely interesting. Without any further ado, I'd like to just mention that this is actually our 34th webinar for the IAA. And it actually is a great honor and privilege to be actually able to combine it with the IOA. So hopefully we will continue to have these joint ventures in the future, which will hopefully increase the viewership of these webinars. So without any further ado, I'll hand it over to Rajeev to take the evening forward. Rajeev, over to you.
Rajeev, you're still muted.
Thank you, Ronen. Thank you, Dr. Ram. It's a wonderful occasion that we all are here together, and I can see the 43 participants already on the screen. The number is increasing. I just am the immediate past president of Indian Arthroplasty, which now is under the guidance of Ronen Roy. We have had this, Ronen is right, that this is the 34th Indian Arthroplasty Association webinar. And there is a great demand of this webinar because our younger colleagues especially are very excited about that they can see on these focus topics various issues, and they can learn from time to time, and they can go back to the member section of Indian Arthroplasty Association on the website and pull out the required webinar topic. So we are very happy to continue this tradition, and hopefully we will continue it for all this year. I, as the chair of the Arthroplasty Committee of Indian Orthopedic Association, will definitely try my level best to ensure that the academics in as regards to the arthroplasty continues, and I'm sure that Ronen and Rakesh and all our other friends will support me in this process. I'll request Rakesh to initiate, because Rakesh is the convener of this webinar, focus webinar on periprosthetic fractures, how we should manage, especially for the cases of the knee. Rakesh, please go ahead.
Thank you, Rajeev. These webinars which we are doing normally invites one talk, which is the general talk, and then we normally have case-based presentations so that people actually are well aware and they're very interested also in that. So all the talks will be case-based and with some messages passed around. So Abhay will be going first, and then followed by I think Debabrata Padhy, then Rajeev himself, Neeraj, Kunal, then me and John, and then Dr. Sen. So I think I'll, without wasting any more time, I'll let Abhay carry on with his talk, and I'll request all the delegates, if you have any queries, put it in the chat box. Of course, some questions will be directly asked to the presenters by the faculty here itself. But for the delegates, I would suggest that you put in your chat box. And if the question is a general question, then we'll probably answer in chat box itself. But if it's something very relevant, then we'll probably discuss it in our discussion session. Thank you. Abhay, all over to you.
Thank you so much. Can you hear me and can you see my screen?
Yeah, both okay,
Yes,
Abhay?
Abhay. Yes.
Okay, thank you so much to the IAA and the IOA for this opportunity. My brief is to start the discussion with talking on the classification. So when we look at periprosthetic fractures, we see that they're about up to 5% of injuries post an arthroplasty. And what we see most oftenly is that when we talk of periprosthetic fractures around the knee, it is the supracondylar fracture of the femur, to the IAA and the IOA. And a lot of these injuries are intraoperative fractures. The incidence of intraoperative injuries or fractures happen much more in revision situations than they do in primary situations, as has been pointed out and published. The next most common injury is the tibial fractures, which occur in about 0.1% intraoperatively and about 0.4% postoperatively. And the least common are the patellar fractures. But what is most important to highlight here is that the incidence of patellar fractures is the maximum in patellas which are resurfaced. So for all the PS users who do resurface the patella as well, that is the culprit. And the incidence is fairly low when it comes to an unresurfaced patella. But what is of maximum treatment relevance is that a lot of these injuries are asymptomatic or minimally symptomatic. With a lot of them get identified on post-operative X-rays or classification. So when we unfortunately or unfortunately, a lot of them get diagnosed up to almost 3 years. So there is sometimes a neglect or a missed diagnosis for up to 3 years. So when we talk of periprosthetic fractures, they're essentially intraoperative or post-operative situations. And the intraoperative ones are essentially because of stress risers created due to cortical perforations or sometimes excessive resections. Post-operatively, a lot of times they happen when patients sustain injuries or falls, or in certain situations where because of a pathology, the bone starts to osteolize, or there is a significant osteopenia or osteoporosis, which predisposes a weak bone to fracture. Now, the classifications essentially can be described as classifications for 3 basic types. So the supracondylar fractures have been classified historically since 1967 by Su and by other scientists. But the main classification is the Rohrbeck and Taylor classification, which was given in 1997. But what we are going to talk today is something which has got more practical relevance. So I will talk not of the Rohrbeck's classification, but I will talk of the Rees classification of 2018, which gives a prognostic treatment guideline as to how you need to treat these supracondylar fractures based on the type of injury. And the second most common is the Felix classification for proximal tibial fractures, and then the Patella fractures, which is being classified by Goldberg. Now, another classification system has been attempted, and this has been essentially a job that has been taken up by the AO trauma and the AO recon community in trying to integrate these injuries. And this is the task force classification, which has come out in 2020. And they've tried to put everything into one classification system. So, the shoulder, the elbow, the hip, the knee, the ankle, everything, the wrist, everything put into one classification. So we will touch upon this classification if I'm not taking too much time. So the first one is the supracondylar fracture femur. And these have been classified essentially into 5 types. So in type 1, the Rees classification says that this is essentially a transverse or a short oblique supracondylar fracture, where the fracture line reaches up to the anterior flange of the femoral component. And these are fractures which can be treated very conveniently by a unilateral lateral compression plate or a locking compression plate. And where you have an open box, you can do a retrograde intramedullary nail. The type 2s are the oblique or the reverse oblique fractures, where the fracture again can go up to the anterior flange of the femoral component. And these again are very amenable to a locking compression plate, unilateral, one side, usually lateral. Type 3 fractures are fractures where the fracture line tends to go fairly below the anterior flange of the femoral component. They usually have 2 types, the fracture fragment or the fracture plane going inferomedially or inferolaterally. And these are fractures which will need not just a unilateral plate, but they will need a bicortical, 2 plates or dual fixations for stability. Type 4 fractures are fractures which are transverse usually and are present around the tip of the extension rod. And these are amenable to polyaxial variable angle locking plates. And type 5 fractures are the ones where they have a shattered distal femur with comminution. And these are essentially the fractures where the fracture fragments get into the collaterals and they cause instability or loosening of the inherent prosthetic joint, which requires a revision with either a constrained prosthesis or a hinge. So that's a re-type 1 where you have a fracture which is going up to the supracondylar or the anterior flange, which just is amenable to a unilateral locking compression plate. A re-type 2 where the fracture line is a short oblique instead of a transverse or a minimally displaced fracture line, where the fracture can go up to either inferomedially or inferolaterally, again amenable to a locking compression plate. Type 3 fractures where you have a medial comminution, and these are fractures which go below the anterior flange of the femoral component. So these require 2 plates or dual fixations. Type 4s where the fracture line is usually a transverse fracture at the tip of the extension stem, which requires a fixation by a locking compression plate or a variable angle polyaxial plate. And type 5 where the fracture is where the prosthetic component is loose, and this essentially requires a revision. Now, coming to the periprosthetic fractures of the tibia, essentially they are seen in about 1.5% of all total knee arthroplasties. And Felix in '97 published their classification in Clinical Orthopedics, which essentially says that there are 4 types of periprosthetic fractures of the proximal tibia. One is a fracture of the tibial condyle. Type 2 is a fracture which is around the stem of the tibial component. Type 3 are fractures which are clear of the tibial component and are present distal to the tibial component. And type 4 are fractures which are present, which are fractures of the tibial tuberosity. Now, each of these fractures, the treatment bearing essentially has to involve 3 different subcategories or sub-decision-making factors. And those are type A, where the prosthesis is stable, type B is where the prosthesis is loose, and type C fractures where the prosthesis, basically the fracture is an intraoperative fracture. And these require to be treated intraoperatively if detected. So that's an example of a type 1C where it's an intraoperative fracture of the tibial condyle, which was treated with a locking compression plate as an internal fixator. A type 2C where the ununited fracture of the tibial component just proximal to the stem required a fixation and stabilization with a plate. A type 3C where the fracture line is distal to the tibial to the extension rod, And this required a reduction in fixation of the fracture with a locking compression plate. And type 4, this has been borrowed by from the Rees published article, which are fractures of the tibial tuberosity. Now, coming to periprosthetic fractures of the patella, they are usually seen in patellas which have been resurfaced and not so much in those which are not resurfaced. And Goldberg gave a classification which essentially describes the patella fractures into 4 types. So type 1 essentially are the marginal fractures where the fracture line does not eat into the implant cement composite or the quadriceps mechanism, as you see in the picture on top. The type 2 are fractures which disrupt the quadriceps mechanism and the fixation mechanism of the implant. Type 3 fractures are basically inferior pole fractures, which can have type 2 types. The 3A is where there is a disruption of the ligamentum patellae, and type 3B where there is no disruption of the ligamentum patellae. And type 4, which are basically fracture dislocations because of shear stresses on because of the injury. Now, there is another classification system which is tried to integrate, and this is a very recent classification system where everything has been put into one place. So they describe there is a mnemonic of the unified classification system by Duncan and Masry, by Masry. Essentially says type A are the apophyseal, type B eat into the bed of the implant, which is the substance of the implant. Type C are those which are clear of the implant, so they are not near the implant. Type D are basically present in fractures in bones where, one bone divides 2 implants. So they are interprosthetic fractures. Type E are the ones where there is a fracture around one arthroplasty involving 2 bones, like you can have a femur fracture and a tibia fracture in a total knee arthroplasty. And type F are fractures which are basically in a bone which is facing the implant, like you can have it in a hemiarthroplasty. So these are basically the types where A is the fracture of the apophysis. The point in question and consideration here is the tibial tuberosity and the superior and the inferior poles of the patella. So these are apophyseal ones. Type 2 are classified as fractures which are involving the bed of the implant, so they can be well flexed. So essentially the question to be asked is the stability of the implant and the quality of the bone. Type C are those fractures which are clear of the implant. So they are basically treated separate. The implant is stable and essentially one needs to treat only the fracture. Type D are interprosthetic fractures, which can involve any of these bones. So the bone in question here is the knee and the tibia. So these are fractures which are basically 1 bone and 2 implants. Type E are the fractures where they involve 2 bones and a single implant. So the fractures of the femur and the fracture of the proximal tibia, which Dr. Sen is going to talk of today. And so that's the take home for the different types of classifications for the universal take home fractures. So when we essentially talk of the types of fractures periprosthetic, we have to be clear that if there is a hardware, it needs to be removed 3 months before. If we are retaining the hardware, if we are removing the hardware at surgery, we need to stem the implant. Avoid eccentric placement. Take care that if the patella is not everting, then it has to be lateralized. One has to be careful about not notching the femur more than 30%. One has to be careful in stiff situations that fragments need to be stabilized. One needs to take X-ray exposures, and one needs to do additional soft tissue releases to expose better. So all in all, when you come to classification and their relevance, basically periprosthetic fractures in total knee should be avoided by meticulous techniques. And the classifications essentially are based on describing whether or not the fracture has affected the implant stability, what is the displacement of the fracture, and what is the quality of the bone stock, which will essentially decide how to treat these fractures. Thank you so much for your time.
Thank you, Abhay. I think it was a very well explained classification of periprosthetic fractures and especially their clinical relevance. We'll have a discussion after the first 3 talks, which are about the fractures, fracture fixation. Rakesh, I think it's okay, right?
Yeah, it's fine.
We have, yeah. So we'll invite the next speaker, Dr. Debabrata Padhy, a very senior surgeon from Bhubaneswar. Dr. Padhy will be speaking on distal femoral fracture and single plate fixation. Dr. Padhy, please.
Good evening to you all. At the outset, I thank the Indian Orthopedic Association and the Indian Arthroplasty Association for giving me this opportunity to present a case-based discussion on the distal femur periprosthetic fracture. So as we know, the periprosthetic fracture in the distal femur are very common in females, in osteoporotic individuals, in individuals who have neuromuscular or cognitive disorders, medication related when their long-term steroid intake is there, when there is inflammatory arthritis like rheumatoid arthritis, infection, when it is procedure related, when there is notching in the primary TKR, then there is chances of distal femur fractures are there. And it's implant related, when you use more of constrained implants, chances of periprosthetic fractures in osteoporotic individuals are common. So my patient was a 70-year-old female, a tall, obese, hypertensive, and hypothyroid patient, has a history of trivial fall, and 6 years following the index surgery, she presented with a fracture. So going into the pathophysiology of the distal femur, we can see that there is loss of bone mineral density up to 27% near the anterior flange, for which these distal femur fractures are very common in a periprosthetic situation. Significant difference is there in the modulus of elasticity between the implant and the bone, and also between the bone and the cement. So thus it causes chances of increased fracture risk in a periprosthetic situation. So this was the X-ray. There's a long oblique fracture with lateral comminution and the lateral end going up to the distal end of the near the implant, and the tibial component tibial part was intact. So first we have to classify and see how we can go for planning. And as the old classifications, we go by the Rorabeck and Sue classification. It's a type 2 Rorabeck and type 3 Sue, and fracture distal to the femoral component flange. Thus, we have to see for the status of the component. In these cases, we have to first look for the status of the component. If it is loose or if it is intact, according the planning will change. And the fracture pattern as regards to the amount of comminution and the pattern of the fracture, the obliquity of the fracture, and from the fracture where it is starting and where it is ending, all these has to be seen for. The bone quality has to be looked for. Residual bone stock which is present, if it is amenable for fixation, has to be seen. And the feature of the retained implant has to be kept in mind while going for the fixation, more so in intramedullary nailing cases, if you are going for nailing these patients. So usually we go for a CT scan to see the first of all, see for the implant situation. If it is loose, there is sign of any laxity in the joint as compared to the bone, or and to look for any comminution which is present near the implant, which can affect our fixation, and we can plan for fixation either single plate or double plate. So this picture shows whenever the fracture is too much proximal and a simple fracture, we can go for intramedullary nailing, and when it goes little distally, plating is a better option. And as we'll discuss further in the webinar, the single plate, double plate, and revision arthroplasty are different choices for different types of fractures. So the options of this fracture can be intramedullary nail or a plate. So first, when you are thinking of a intramedullary nail, we have to see that if we are planning for a retrograde nail or an antegrade nail, because IM nailing are good load sharing device for length stable fractures, and early weight bearing can be done. Thus, option for static and dynamic locking according to the situation can be planned, and so IM nail will be a better option for proximal fractures. But we have to look for the box. That is, if it is a closed box or an open box implant, it is very difficult for fixation distally, distal screws when the fracture is very distal and not much good bone is available. And the malalignment is common because when you are doing a retrograde nailing, the posterior endpoint inherently comes because of the position of the implant, position of the box. You can, and more so in the CR where the PCL is intact, and to prevent the PCL injury, we can go more posteriorly, and this may cause malalignment in the sagittal plane hyperextension at the fracture site. So locking plate usually they are load sharing device, angle stable device, which fixed by AO principles like relative stability and absolute stability. They prevent stress rises around the joint implants, and they help in biological bridge plating. It is good for union and better for communications. Combination of non-locking screws for fracture reduction and locking for flexibility in fixation helps in fixation, good fixation through locking plates for distal fractures. Minimally invasive techniques nowadays have decreased the non-union rates to maximum. Almost most of the fractures, they unite following a minimally invasive technique when it is chosen correctly. But there is coronal malalignment, which is very common, which has to be prevented by good screening and alignment, measurement, and fixation technique. Limited screw options for distal femur fractures when the fracture is very distal, and long-term non-weight bearing is detrimental for medically ill patients. Usually in these cases, we may go up to 12 weeks of restriction of mobility for union to happen. So this was 6 weeks post-op for the index case, which we are discussing, and we started on gradual weight bearing after seeing this X-ray with walker support. The post-op protocol usually followed in this case on-bed exercises with commode transport for 6 weeks, followed by gradual weight bearing with walker. Depending on the fixation status, precautions can be done up to 12 weeks. If creatinine is normal, management of osteoporosis with injection teriparatide helps in union, early union, and it was started in this case. So at 3 months, fracture uniting with exuberant callus, distal femur fracture, you can see the amount of bridging callus in both the views. At 5 months, the patient was still walking with weight bearing with walker, and the patient complained of a sudden onset of pain in the mid-thigh level while walking. As you remember, patient was an obese patient and tall obese patient. So after doing the X-ray, we found out there was a fracture in the distal shaft of the femur inside the implant content. So what are the causes? The causes may be a stress riser might be there. Plate might be shorter plate. We should have put a longer plate to prevent all these type of stress rises. There may be excessive forward bowing of the femur, where the plate was ending, the bowing was too much for a stress riser to happen. And the patient, as we remember, is obese, and we started early weight bearing at 6 weeks. So on going back to the X-ray, we saw that there was a line of lucency at the site of the hole, which was a drill hole, which was done during surgery, but no screw was put inside it. So, and the fracture has occurred through that, and this was not seen in the pre-op X-ray. So we remember that there was a drill hole which we did, and a single drill hole which was done, and no screw was put inside it. So planning of a antegrade nailing was done, and because it was 5 months post-op, so we decided on keeping on the plate there, because we are not sure of the fixation of the distal callus formation. There was good callus, but fixation we are not sure because of 5 months post-op. And we changed all the screws into unicortical screws, and a static locking screw was put through the plate and through the nail. And this was the AP view. And at 3 months, a patient was started on gradual weight bearing, and patient had good union at the recent fracture site. So we should know the algorithm for decision for this type of fracture. Whenever the patient optimizes for surgery, because usually these patients are medically ill patients, and we should not straightforward go for surgery. The patient should be medically fit for surgery, and whenever there is an open wound, or the patient is waiting for surgery for optimization, external fixation is a good option till wound heals. Whenever there is a closed fracture, we should see if the fracture is proximal to the implant, if it is fracture is within 2 centimeters of the anterior flange, or fracture is distal to the flange. So when we look into this, then we should look that if the implant is intact or implant is loose. And whenever we see that implant, the status of the implant, we should see the fracture is a simple fracture or a comminuted fracture, and where is the comminution. Thus, there are long range of options which we can use depending on the permutation combination of whatever seen in the particular case, from IM nail to a contoured LCP with osteosynthesis and revision, or a distal femur replacement or a revision alone. And whenever you are using contoured plate, to decide on the lateral plating or dual plating depends on the amount of comminution, as we'll discuss later in the subsequent talks. Thank you for your patient hearing.
Thank you so much, Dr. Debabrata Padhy. I think it was a very well explained single plate fixation device system. We'll have the questions after the next talk. And I think Dr. Neeraj is ready with his talk. Dr. Agarwal, he'll be speaking on dual plate fixation for supracondylar fractures of femur. Dr. Agarwal is from Jaipur, senior surgeon. Dr. Agarwal, please go on.
Yeah. So I am audible.
Yes,
I am audible. Yeah. Okay.
Yes, Neeraj.
So thanks, Dr. Rakesh, Dr. Rajeev, for giving me the chance. And I will speak on the dual plate fixation of the periprosthetic femur fracture. And I can say that this concept of dual plate actually has evolved out of the knowledge and out of the complications which we have seen in last few years of arthroplasty practice. Here we all agree that periprosthetic fractures have an increasing incidence. They still require knowledge because this is not a routine trauma. It is an evolving science where there is an implant and the mode of injuries are different. Plus you are dealing with a situation where there is a very poor bone stock and you have to actually trace the good bone for fixation. And there is a significant osteoporosis. They are elderly people. So first of all, I will put this X-ray, a very routine looking X-ray. You can see it, but there was a significant notching. Now, always prevent this notching. If you have stemmed femur in your OR, then put at that moment, else you will be in difficult scenario. And it happened. There was a fracture, and again it was again a wrong choice of implant where it was fixed with 3 or 4 K-wires, because this is going to fail within a month or so, and patient will be in a bigger trouble. The second case, now you can see here there is a fracture which was treated. I'm sorry. Here there is a fracture. It was a low fracture and it was treated with a single plate. And you can see that after 6 months, what's happening? The whole construct is now going in varus and it's going to fail. Third picture. Here you can see that osteoporous bone. Definitely you have a good length of bone, but since it was osteoporosis, there was some comminution during the surgery, and there you can see in the immediate post-op X-ray, and again it failed because patient started early weight bearing without the surgeon's knowledge. So these 3 complications I have told that they happen and we see in our day-to-day life, and we need to check for it. Here one more case. Again there was a plate and it was put, and again it was a failure of the plate because of within 5 months of surgery because of early weight bearing, and no callus was there. See, so this classification has already been discussed by Rorabeck and Taylor. This is type 1 is again undisplaced, type 2 is the displaced with stable prosthesis, and type 3 is it's a fracture but the loose prosthesis. So type 3 has clear management that you need to replace everything with some LRS or something like that. Implant the trauma surgery or with plates and nails will not suffice. When we go through the literature review, you will find conservative management methods. You will find retrograde intramedullary nailing methods. You will also find locking plates, but the locking plates will be the one plate. And when I was going through the literature, I found that actually we don't have much data where the dual plate has been compared with any other modes of fixation. So one thing is very clear, that either you go for a nailing or you go for a single plate, but you don't have good data which supports dual plate. So I say it's an evolving science. Second thing, again, few people are using nail plate combo, which can be used in very special cases, but again, you don't have literature about the nail plate combo comparing with the other methods. Intramedullary nail, yes, it can be done, but it has actually many disadvantages. Like it cannot be done in all the implant designs. If the fracture is very low, you cannot you cannot choose your axis of your screws. You cannot. It gives recurvatum. Fracture may go in higher chances of malunion. Then to perform it in patients of patella bhaja is extremely difficult. And if there is already a stem, then you cannot plan it. So all the things come down to the decision of that what we should do. So definitely locking plates are an answer for this fracture, but when to do a locking plate? The decision is that when to do a locking plate. So whenever a patient comes to me, what I see first in the X-ray is that where is my fracture line? Now, if my fracture line has a tip on the apex, you can see in this X-ray, in this X-ray, you can see with the red arrow that there is a medial tip apex and the lateral side, it is below. Now, if this is the picture, which is below the flange, then these are the fractures where you cannot suffice a single plate. You need to trace that medial good chunk of bone and you need to put a plate on the lateral side. Simultaneously, also put a plate on the medial side. This is important. If you don't construct it in this manner, then it's going to fail. Second thing, implant choice. Now, implant, there are multiple type of implants which are available in plating armamentarium. One is the variable angle plates, which are very good in particular scenario of periprosthetic fractures, because you get that 20-25 degrees of extra angulation of the screw where you can put it. And this is important when you are actually tracing the good bone for your fixation. And also now Indian companies have come with the medial femoral condylar plates. I'm sorry if anyone can know, but I don't know any good company like Synthesor. They have the medial femoral condyle plate. So you can have a plate on the lateral aspect and you can have a plate of medial femoral condyle with multiple screw option. Third is approach. Now approach, it depends that what is the fracture displacement and whether you are able to reduce it on table or not. Now, if you are able to reduce the fracture by indirect method of traction and putting some pillows and small pillows here and there, then you can always go for a submuscular approach where you can apply a 6 to 8 centimeter incision on the lateral aspect of the knee, then go through the TFL and then make a space subperiosteal and go and put a plate by a MIPO technique and fix it. But again, the approach sometimes is confusing because we need to have a 3D picture of the fracture. If you fix a fracture and the alignment is not good, then it's going to fail and your knee implant will wear very fast. So approach is important, but in most of my cases, I open it by the lateral parapatellar approach and I do the surgery in an approach in this fashion. So this is one case which I have told. Then second case, this is a patient in which there is a metaphyseal comminution and a chunk of bone in the epiphysis. So the second important point, when to put a dual plate. Now in this patient, first you reduce the fracture and you put a lateral plate. Now after putting the lateral plate, you do a gentle stress test. And if you see that there is still some amount of movement, then don't leave the patient and put a medial plate. So you have a construct of medial and lateral plate. So this is the second case. This is the third patient which I have told. So this is a failure of implant. The implant is broken. So the dual plate was put so as to put and the fracture united well. And so the take home message is very clear that you as our experience is growing in arthroplasty, the dual plate gives you a good, stable and a strong construct in these osteoporotic bones. And probably now, as my experience is growing, I am going more in favor of dual plating. Thank you.
Thank you, Dr. Neeraj. Dr. Rakesh, can I request you to carry on the discussion now?
We can actually. I've actually initiated the discussion on the chat box. So I'll just go through the chat box actually.
Yeah,
so the first one.
There are many questions on the chat box. Yeah.
We'll not discuss all of them. I think Abhay has been very good to answer most of it.
Right.
So the first one is, Neeraj has tried to answer some of them. When to use one plate and when to use double plate. So anybody has a take on that?
Yes.
Dr. Padhy?
Dr. Padhy,
Yeah.
yes.
Actually, whenever you see a fracture, oblique fracture, which is going towards the lateral end, then it is stable on with only a lateral plate, and there is not much comminution on the medial side. Whenever there is medial long length of medial comminution and any simple oblique fracture which is going towards the distal end of the medial side, then you have to add it with a medial plate. That is what I feel. So this answers your question, I believe.
No, I think this is one of the reasons we use. There are a lot many other reasons. I think Neeraj also has enumerated. So I'll just tell you what the AO thinks about these fractures. And I'll just enumerate all of that because, so one is the reverse oblique, which you just spoken about, where the lower part is in the zone of the process and lower than the medial side. So because then what happens is when you're trying to fix all these fractures from lateral side, you just don't have 4 different screws which will fix the lateral side. So in that case, you will have to come on the medial side. So that's one. The number 2 would be if you have severe osteoporosis. So when you're putting, even in these locking screws, when you're putting in the implants, you just don't seem to have that bite. So in that case, don't have a hesitation to go medial. The third will be, in general, the fracture is very distal. So that will be third. And if you have medial combination, which Neeraj I think has already mentioned. So if you have a medial combination, even for trauma cases, if you remember now the AOA is proposing to actually go medial. And the one will be, one other reason would be very old patients who are generally you would want to probably do what Rajeev's talk will be about replacing distally in normal, but they're not fit enough to withstand that major surgery. So in that case, you actually put plates on both sides, or you've already done a replacement with a tumor prosthesis, but you now had a periprosthetic fracture, so you just don't have enough bone to fix. So in this case, you'll have to come immediately. And also if you have PS designs, in those cases, you just don't have screws to go through all the way from lateral to medial. So again, you may have to have partial screws both on medial and both on lateral side. So I think all these will be reasons for putting 2 plates. So the next question I generated was how long the plate should be. And I heard some very nice answers, but not the actual answer we were looking for. So anybody has a take on that? How long the plate should be?
Dr. Neeraj.
So the plate should be longer and better. So you should try to span the more area and put screws with a gap. Then it is always better.
So the case which you showed, the last one where you had distal femur fracture, that plate was very small applied. And the other philosophy which was wrong in there was the screws were very close to the fracture site. So the working length of your plate was not very good. So I think from now, I think... Can
I opine on that?
Yeah, Abhay.
Yeah. Abhay,
so
please.
Basically, your plate, if it's a supracondylar fracture femur, must cross this isthmus. That's one, rule number 1, broadly. Second is your cortical screw density should be 0.5. That means your spacing of the screws should not be too, because they cause stress rises, especially in peri-arthroplasty situations where plates around proximal arthroplasty components will be unicortical. Third is that normally if you have combination, then the span of the plate should be at least more than 3 times or at least 3 times the length of the comminuted segment supracondylally. So few broad statements which will basically decide the length of the plate. But by and large, if we can take the plate beyond the isthmus, that's a stable plate. And usually these are the 13 to 15 hole plates. The other thing is that one needs to have the add-on components of or to these plates, because if you have a prosthesis, a hemi or a total proximally, then you'll not be able to get bicortical screws. So you need to have add-on components on these plates, which will put screws which are intracortical screws, both anterior and posterior to your plate. And that actually will get stabilization.
Very right. Thank you, Abhay. There is a question on the chat box, Rakesh, that what is the role of the retrograde nailing in a crucial retaining design? So I'll request both the speakers to give their opinion.
Yeah, okay. I think that was not covered by anybody. So Neeraj and Debu, do you want to talk about when to nail?
So,
okay, Neeraj, you can go ahead.
Please, Padhy, sir.
Okay, whenever you are thinking of a retrograde nail, first of all, you have to see that you have enough bone distally for the distal screws. That is one point. And better to nail the fractures which are above the flange. That means there is good bone and the comminution is not much. If at all some comminution is there, you should go for a static locking and dynamic in case of a simple fracture. And whenever you are going for a retrograde nail, you should be aware of the implant. And there is a good literature that is by Thompson et al. In 2014. I had quoted that. And they have given the notch area of different implants. And that is a good thing which you should keep with you and see how much the space is there for you to go ahead and do a retrograde nailing. And in shear cases, because PCL is intact, in those cases, you should prevent damage to the PCL, and you should try to keep the entry point as anterior possible, because you will tend to go posteriorly. And if you go posteriorly, there is chance that you will angulate the fracture site. In the there will be hyperextension at the fracture site, and that has to be prevented.
Right. Thank you, Padhy.
One basic question, how do you actually assess the stability of the implant?
I had put in that question also.
In a retrograde nailing, Dr. Padhy, how do you assess the stability?
Not retrograde nailing,
in general, yeah, that's in general.
Any supracondylar fracture, how to know
if the implant is stable or not?
At least we should have an idea of the preoperatively from the CT scan. Whenever there is lucency around the implant, whenever you see a lucency around the tibia, you can think of lucency around the femur also if it is masked by the fracture. And if there is a lucency around the implant as such, then you should think that it may be loose. But in all cases, when the fracture is very distal, the revision implants should be kept, and also distal femur replacement prosthesis also be in the backup, so that you don't know what is the situation. If you are planning for a fixation of the distal femur and you think that maybe, and preoperatively you have seen the CT scan, intraoperatively you can know, but you have to have a backup to go ahead and do it.
Right.
Even stress views actually help.
Stress view may not help, I believe. I don't know. I have not done stress views, but fracture site opening and masking by the fracture site maybe.
No, the stress views won't help much, because you will actually move at the fracture site. You won't be moving actually at the loosening site. So one pre-fracture is one exercise you need to look at. So look at the sequential exercise if the patient has. Then if the patient was already loose, and sometimes you can make that out, and that may be the reason for the fracture, then you already know that the implant is loose. The next is post-fracture, but pre-operative. In those cases, what you do is you look at your X-ray and CT scans very carefully. So if you find that the pieces of condyles have actually come outside the implant surface, which normally there is always some bone there. But if you feel a large chunk has come out, it's very likely the implant is loose. If any of the condyle, more than 1/3 on CT scans particularly, if you feel that they've actually come out on reconstructions, then you know that this implant's getting loose. But many times, I think when we are in doubtful cases also, it's not bad idea to fix these fractures and then come back and do a simple revision later on. So don't chop off femurs just because you thought it might be loose. That's my only say in this.
Right. Abhay, you have a point?
Abhay.
Yeah. So we are talking of post-op situations. So the one thing is that if your patient has been having recurrent effusions, then probably you're looking at unstable implants, and especially if the patient is mobile. So that's one. Second thing is that if your patient has evolving deformity, which is increasing, then probably you're looking at loose implants with the patient having difficulty in initiation of movement, getting up from sitting position. That's number two. Third is that if the length of the fracture is crossing more than 25% of the tibial extension rod and the base plate. So 25% of the implant surface, if the fracture is exceeding that, then the chances of the implant being loose are much higher. And so those are three broad categories in post-operative things. Fourth is obviously if you have subsidence, if you have big fragments, and then you essentially are walking into a loose implant. The thing that we have not discussed yet is the intra-op situation. So once you have an intraoperative fracture, it is important to reduce those fractures, stabilize them with K-wires, and then take the joint through its range of motion to see whether that fragment, fixation or stabilization is actually stabilizing the fracture or not. And that actually is very important to judge on the table before we decide on what to do with that fracture situation.
So Abhay, just one more point in this. What we have not discussed is occasionally what you will see that because of the fracture, or perhaps there was a subtle hint before the fracture itself that the actual poly is not stable anymore, that it is actually loose. So be very careful. Once you fix these fractures, retest this knee, and you might suddenly find that you might need to go one size up in the poly, or at least warn this patient that this knee is a bit loose. I may have to come back and do a poly revision.
Right.
So be very careful.
Rakesh,
And so we can go ahead now, Rajeev.
Right.
So I will ask Rajeev to go with talk of when to do distal femur replacement rather than fixation.
I hope you can see. Thank you so much, Indian Orthopedic Association and Indian Arthroplasty Association, to come together and give us this opportunity of discussing a very important topic. I've been asked by Rakesh to speak on revision for periprosthetic fracture in total knee arthroplasty. Periprosthetic fracture post-TK is a very serious complication. Are common, and tibial fractures are relatively lesser common. Major risk factors we have already discussed: osteoporosis and unstable total knee, implant loosening. Probably these are these have been enumerated in the earlier discussion. Now the focus point is when you should revise. The criteria should be when you have a poor bone quality with a very distal fracture and a loose prosthesis. So that these are the requirements where you have to probably go for a revision of the implant. You need a femoral or tibial implant with a long stem plus or not needed supplementary fixation. You may have the allograft with you if it is possible. Distal femur or proximal tibial replacement implants also should be ready if the situation demands so. Tumor prosthesis may be used in cases where there is a loss of proximal tibia or the distal femur. And we'll see some of the examples of this. Now, the procedures which are needed are that have been discussed already. The perioperative fracture, if you need an immediate fixation and a stable fixation. If it's a post-operative, we have already discussed the methods of the fixation for the femur. For the tibia, we'll be discussing in next few talks. Revision knee orthoplasty, whether the tibial revision, femoral revision, or revising both the components or a mega process. We just go through, I'll just make you run through the situations. For example, this patient who had a total knee arthroplasty, she had a fall, a tibial fracture, and loose tibial component. And we can see that tibial fracture, when it happens, very proximal tibial fracture in an osteoporotic bone, this is just like a bag of bones. It's a very tough situation to deal with. The only option is because you don't have a place to fix the bone. So you have to revise it with the extension stem, as you see the example here. And that's what you see this patient at 6 months follow-up. Another situation where you have the osteoporotic patient, obese patient, one has to be careful that this patient can have a fall or just stumble on the knee and can have a fracture. That's what happened with this patient. This is the primary knee arthroplasty done on the right side. The left side was already operated 10 years back. This 76-year-old patient, she had a fracture after 1 month of the index surgery on the right knee. And that's what you see on the table. When I fixed it up initially with the screws, and I found that this is not a stable fixation at all. When we went into, when we exposed it more, and you can see that the fracture, how the fracture pattern is. And you can see that the whole of the femoral component is mobile. There is hardly any bone distally. In this kind of a situation, when you find it is to plan the second thing, and then you have to revise the femoral component in this patient, the use of the extension stem, the distal wedges, and the bone graft. When you use all these things, that's what you have the result. And that's what you see this patient post-operative after the revision of the right knee. And you can get the reasonably good function in these cases, maybe not as good as 130, 120 degrees, but reasonable function can be achieved easily. Another patient with a distal femur fracture, non-union with intact plate. Plate is not broken, but you still have a non-union, and you can see that in this patient, you don't have enough fixation distally. And the fracture is very clearly visible. And in these cases, you may have a plan to go for a mega prosthesis. That's how you just, the minimum size of the femur, distal femur that you'll have to remove in this kind of a situation. And that's what you'll take out the distal femur by releasing the tissues posteriorly, fixing up the implant well. And then you see that the rotation hinge is a very good option in such a situation. The tissues fall back very easily and very well. And that's what you see. The fixation, if it is good, the balancing, if it is good, you can have an excellent function even in these difficult situations. And that's what you see in this patient, having the almost 100-degree function of the knee and full extension. Now, you can have a similar patient with a severe fixed flexion deformity. For example, this patient who had a fracture, she did not come back for the surgery immediately, and she reached us almost 4 months after the with a severe fixed flexion deformity. And here in this case, more than the fixation, it was how to correct this distal femoral fragment, how to bring it in alignment with it, which was found to be very, very difficult. And this patient also may be a suitable candidate for distal femoral megaprosthesis. And that's what you see these patients. And these patients minded that we will have for quite some time the extension leg, which will recover well with time. And that's what you see this patient at 5 years doing absolutely well. Now, distal femoral fracture, where you have a fixation of the plate may break, and this patient again will have a severe deformity and non-union. This patient also can be treated very well with a megaprosthesis. That's what we see here. Now, this patient is coming to us after 1.5 years of the surgery. That's what you see. You remove the distal femoral fragment, you make the shape of it, you fix it well. What is very important is that you use extension stem with more than 10 millimeter diameter. And once it is done, now this usually functions very well. Sorry about the sound. You can see this is the various implant components which need to be fixed. And rotation hinge is a very useful implant in this case. One must take care of the rotation of the femoral component, because if you don't look after the correct rotation, you will have a problem of the patellofemoral joint, and it will not be easy to have a good function in these patients. That's what we see this patient post revision with using a megaprosthesis, and these patients can have a almost very quick result, and in about 1 month to 3 months time, they can regain all the extension leg that they had. Now, prevention of a periprosthetic fracture is a very important thing. Probably that is one part that I will stress upon my younger colleagues as much as possible, especially in an osteoporotic bone. If you have to remove the implant, it is better not to use the hammer, but the proper device to remove the implant. Notching is another very important thing. Notching should be avoided, especially in an osteoporotic bone. My take-home message from my side will be that protect your patient after the primary knee arthroplasty. Build up the bone strength. Use whatever material, whatever medication we have to build up the bone strength. Exercises. Avoid surgical mistakes as much possible, and choose the right procedure for your patient. Conclusion is, if the fracture is very distal, not fixable, or the implant is loose, then the revision arthroplasty is the only option. And we have just seen few examples of various types of the revision arthroplasty. Stem extender and augments and sleeve should be available when you are doing a revision of this kind, which is very difficult, and keep megaprosthesis as a bailout option in a right kind of indication. Thank you so much. Rakesh.
Yeah, thank you, Rajeev. If you can just come out. I think before moving to the knee and patella side, we'll take questions on any questions for Rajeev? So if there's none, I'll ask you, Rajeev. So when you use this mega prosthesis, the stem, I saw the first case was cemented. Second, I couldn't make out whether it was cemented or not. So which one
no,
should we do?
All are cemented.
All cemented? Yeah.
Right.
So I think in Indian patients, I've also had trouble putting uncemented ones. I have a fear of further cracking them up when you're putting this huge uncemented one. So I don't know what the other faculty feels.
Absolutely. The uncemented ones are really not suitable for our population.
Okay, so
the stems are too wide.
Yeah, and since Rakesh, we have had a significant follow-up of these patients of more than 10 years in many cases. One thing very important that come out is that the stem with the mega prosthesis that you use should always be more than 10 millimeter, 11 or 12 is preferable, because there is a huge risk at 7 to 8 years for the fracture of the stem, which is a major thing. And another take home is that the seating of the implant on the bone should be very good, because if there is a gap between the bone and the implant, and there is a part of the cement in that place, that becomes the stress riser, and that should be avoided if it is possible.
Very good. I think that was another question. Yeah.
Rakesh, the other thing I'd like to point out is that we've been talking about fracture fixations, but one important factor that we actually need to consider is that in the elderly population, a revision sometimes gets them back on their feet much faster.
Absolutely.
And that is probably one of the key deciding factors, apart from the orthopedic parameters like osteoporosis, comminution, loose prosthesis. So revision can actually be defined more by the patient's profile, which is an equally important factor that should be taken into consideration. Because as trauma surgeons, you always think about the fracture only. But as an arthroplasty surgeon, you really want to get them back on their feet. So I think the fence should be relatively lower when you're deciding for an elderly patient. So decision-making should be based on that. What do you think, John?
So hi, John, welcome.
I think I resent the fact that you said that trauma surgeons don't want them, or implied that they don't want them back on their feet. We want it just as much.
No, Ronen,
let me tell you, arthroplasty surgeons want them back on their feet. Well, so do trauma surgeons and arthroplasty surgeons, and you have to find out what is best for that particular patient, I guess. And
so, Ronen, you'll be very surprised that we have some extreme nailers who will nail even distal femur, proximal tibia, add a plate, and make them walk next day. That is the trauma guys doing it. I think John will. John, you must have heard this Martin's talk from the AO group.
Yeah,
that's one extreme. Yeah.
But I think even with plates, you can make them walk. You might have to use both for distal femur and proximal tibia. I mean, the idea of fixing it is to get them to walk. They may not.
But John, my question to you is that most of the cases that I have seen, the failure of the fixation are the cases where the fixation was reasonably good, but the patients have been asked to put full weight bearing or just the as much possible weight bearing at an early time. So don't you think that these patients should wait for a period of month at least before they are
we get them up weight bearing as tolerated. Okay, so they are partial weight bearing, not full weight bearing, but with the elderly, you cannot govern exactly how much weight they're putting on that limb.
Right.
But if you get your fixation, I don't think that should be a problem. What you say is a good fixation may not be a good fixation when I look at it. That's what I mean.
Right. Yeah. Rakesh, before we go to the next talk, there is a question on the chat box regarding what is the long-term outcome of megaprosthesis.
I think you've already said that.
It's a very relevant question, which Deva has already answered on the chat box. I would say that 10 to 15 years is the time which we can give to our patients for sure. But these patients should be followed up more closely than the other patients, because they may have one of the biggest problem is the two major issues. One is the fracture of the stem and failure of the junction, the polywear or the junctional failure.
Yeah. So I think the fixed hinges, we were having trouble, but since the rotational hinges have come in,
Right.
I think the longevity has
better.
really increased.
Right.
Much better.
Right.
Stress rises have reduced significantly.
Right.
So I think Kunal has got one patella. So we'll probably end up cover up patella first. Kunal, you want to go with your?
Yes, sir. Okay. Is this visible?
Yeah, visible and audible. Yeah.
Okay. Good evening, my respected seniors. After a long informative discussion on the long bone periprosthetic fracture, that is femur, now we are shifting our sight to the small bone of the knee joint, that is patella. Though it's a small bone, fracture patella after total knee replacement can be demanding, and more importantly, functional gain after this operation can be compromised also due to more chances of arthrofibrosis, extensor lag, loss of flexion, and more chances of infection and chronic pain. So coming to the case one, the 54-year female Mrs. Das presented to us with a history of pain in her left knee joint with no flexion. She is fixed at 0 degree of extension. Her right knee is also painful, but she can manage flexion almost 62 degree in her right knee. Her inflammatory parameters are increased, so it's secondary arthritis of the knee joint, left knee, with due to the inflammatory arthritis. So we have planned for knee replacement. This is the immediate post-operative X-ray. Post-operatively, she was doing fine for the next 7 days. After going home, suddenly she came back after 7 days with a history of sudden pain and swelling of her operated knee when her physiotherapist tried to flex her knee as much as possible. Our X-ray shows is the patellar fracture. So, as we all know, the periprosthetic patellar fracture have the factors responsible for periprosthetic patellar fracture actually may be patient related, maybe implant related, maybe surgical skills related. So in this case, this is due to the patient related, where this is the osteoporotic movement, this is a rheumatoid, known rheumatoid patient, and there is excessive postoperative flexion tried by the physio. Not only that, if this is seen more in male, and if there is already bone cyst or weakening patella, or in case of revision scenario. So clinically, the patient can able to do her SLR, and there is only mild pain over the knee joint. So we have treated her with long knee brace, and this is a 4-month post-operative X-ray which shows the patella is healed. The patient is now walking and is happy. Coming to the second patient, 67-year patient, female, presented to us with history of pain and swelling both knee, but our concern is left knee in this case. So this is the case of osteoarthritis of the left knee joint. After pre-operative investigation, and she underwent mobile bearing knee replacement and also patellar resurfacing done. This is the immediate post-operative X-ray. It looks satisfactory, and this is the 3-month post-operative X-ray. She was doing fine for next 5 years, and after she had a trivial fall, showing that lower pole patellar fracture. So she is, in this case, this patient is not able to do SLR. So what are the causes for this patient for fracture? So one thing is fall. Another 2 factors those are responsible for the periprosthetic fractures are, number 1 is implant related, where we have seen that if it's a resurfaced patella, specifically with metal backed insect patella, PS implants specifically with TMMA necrosis, and large central patellar plaque. These all lead to the more chances of periprosthetic patellar fracture. And in case of technical scenario, we can see excessive or inadequate patellar resection or limb malalignment that leads to the patellar maltracking. or vascularity. That means the excessive fat pad removal or lateral edge, which leads to the less vascular to the patella and more chances of patellar fracture. So this patient is not able to do SLR, so it's a Goldberg type 3 fracture. So that's why we have to do open reduction and fixation with SS wear, and this is the immediate post-operative X-ray. This is the 3 months the fracture is healed. The patient is doing well. Our next case will be 62-year female, Mrs. Basu. She underwent total knee replacement elsewhere. She presented to us with a swollen knee, which is warm. So it's a periprosthetic fracture. It's a prosthetic joint infection. And X-ray shows the implants is also loose enough. So decision has been made to go for revision in 2 stages. First stage, as you all know, we have to remove the implants and we have to put molded antibiotic cement spacer. So very minutely we can see there is so if we can see this X-ray very minutely, we can see the anterior and medial cortex is very thinned out. So this is the after the normalization of the infective markers. We have planned for her second stage revision, that is removal of the cemented spacers and metal final implantation. So tibial cemented stem with wedges has been used along with the femoral stem also. So here we can see there is loss of the anterior and medial cortex clearly here. So the intraoperatively also assess that her extensor apparatus will not be doing fine and is very weak. So we have to augment the extensor apparatus with semitic graft. And we have done the strengthening with the semitic graft. This is the immediate X-ray, and this is the patient walking. So in short, the treatment algorithm for the periprosthetic patellar fracture, if we see that if there is fracture, the patella which is undisplaced and the implants are stable, then we have to go for cast or functional brace. If the fracture is displaced but the implant is stable, so one have to go for either partial patellectomy or one can choose for non-operative also. If the fracture is displaced and implant is loose, so we have to assess for the availability of the bone stock. If the bone stock is available, that is more than 10 millimeter, then we have to go for revision patelloplasty or excision arthroplasty. And if there is non-availability of the bone stock, have to go for excision arthroplasty plus minus or patrascellular total patellectomy. But the most important thing for periprosthetic patellar fracture is restoration of the extensor mechanism. So my keynotes or take-home message will be extensor mechanism is the most important thing in treating the periprosthetic patellar fracture. We have to avoid resurfacing at the evidence shows the resurfacing patella fracture is almost as high as 21%. We have to respect the vascularity. Communication with physio is very important because whenever how much you want to flexion or how much he or she will go for the patient is very important, and always have revision components available for any unexpected findings. Thank you, sir.
Thank you, Kunal. I think it's an excellent presentation. Before we go to the next topics, which are related to the fixation of the tibia, Rakesh, is it a good idea that we can discuss patella here? You're on mute, Rakesh.
Very good. I think Kunal's gone through conservative, operative, and also reconstruction of extensor apparatus. So any questions for him is more than welcome.
Kunal, the first question I'll ask you.
Yeah,
John, you have the question.
So in your algorithm, I didn't see anything about fixing the fractured patella. Is that not an option?
So it is always an option, but
you haven't got it in your algorithm.
So I have taken the algorithm from Sir Berry's classification, the Berry's paper. So they have given like this. So I have just but opted out. But I have shown.
I was going to ask the same question as John has asked. So Kunal, what is the best way to fix the patella, fracture patella, displaced fracture patella? Of course, we are talking about where the quadriceps expansion is also broken. Because in my opinion, the patella fracture is probably one of the most disastrous fracture in a post joint replacement, and the union and function both are at risk. Abhay, can I ask you?
Sorry, just one second. Also, you have two situations: one where the patella has been replaced, and another where the patella has not been replaced, because that's also fairly common today. So they are totally different sort of games altogether.
Three situations, John. One patella not replaced, one patella replaced, fracture displaced, but still a button is attached.
I mean,
and in second, button is loose. So three different scenarios you have.
Right. John, what is your take on this? You are dealing with so many of trauma patients.
So
because it is a real difficult topic.
So interestingly, the ones that I've had to deal with have not had their patella replaced, and we've gone ahead and fixed them, just as we would fix any other patella fracture. And we've got them to heal and walk around. I'm sure with the patella replaced, it's a totally different situation. It would depend on many factors, including, as Rajesh just mentioned, if the patella is loose or not. If the patella is stable, like for example, that case which he actually showed, I mean, of course, it turned out that the prosthesis was loose. But if it wasn't, I would fix that patella because there was enough room to fix that patella. Although it's a lower pole, you had enough room to do a good fixation of that patella. And to
which case was that, John?
I think the straight question should be, John, that do you do anything special when you have a fracture patella with a knee implant in situ? Do you do anything special for these patients, or you treat them like any other fracture patella?
So that's what I mean. So obviously, if the knee patella has not been replaced, I would treat them like a patella fracture anywhere else. Today, you also have some very fancy plates for the patella, where even with a lot of comminution, you can get it cobbled up together. But obviously, again, if you have a loose prosthesis, that doesn't apply. Then you have to deal with it in a different way altogether. And I have
one.
Abhay, you had a question, I think.
So I have a small pointer to this. As John has already described, the basic important principle and philosophy with patella fractures is that you want an intact quadriceps mechanism.
Yeah, absolutely.
And the two different scenarios are whether the patella has been resurfaced or not resurfaced. So we've talked about the patella which has been not resurfaced. The issue with patella resurfaced is that whether you have an intact patella button or you have a fractured patella button. So anything like a Goldberg 2 or a Goldberg 5 will need a revision of that replacement. So if the patella is very thin, less than 8 millimeters are left, then you can leave the patella safely without doing a revision of the patella component. The one stage where a reconstruction is required, a soft tissue reconstruction, is when you have the patella, the ligamentum patella, which is avulsed. So either the quadriceps mechanism is disrupted at the quadriceps patella junction or at the patella ligamentum patella junction. That will need a ligamentous reconstruction, and you have multiple options like a semi-T repair or an MPFL reconstruction, and there are hosts of soft tissue reconstructions that can be done. But that is an absolute indication for a reconstruction. Otherwise, the patient will be painless, but they will not be able to extend.
Very right, Abhay. Just one small comment I'll mention here.
Rajeev.
That allow me just complete. The one small issue, the quadriceps expansion, the inefficiency of the quadriceps tendon rupture or a ligamentum patellae rupture. All other options are available, but one of the good option is peroneus brevis transfer, which is a very strong tendon, and we have used it in quite a few patients, and it has been very, very successful and surprisingly successful, actually. Ronen, please.
Yeah, I mean, coming back to what Kunal was talking about, how to prevent patella fractures, I think one of the most important things is that we must try and avoid doing lateral releases routinely. That's the first thing. And even if you are doing a release, try and maintain your vessels so that the lateral vascularity is not compromised, because an avascular patella is more prone to fracture. Secondly, as he's pointed out, that resurfacing the patella actually increases the risk of patella fractures, and especially in our patients who have a thin patella. Then if you actually try and maintain 8-9 millimeters of patella, sometimes you end up overstuffing the knee. So by and large, resurfacing in most of our patients is not an option. The other thing is that if you are going to resurface the patella, always try and choose a multi-plague implant. A single plague implant actually has been shown to cause a much higher risk of fracture. And along with that, never use a metal back patella. I mean, most of the metal back designs thankfully have been withdrawn, but there are a few that are still available in the market. So please avoid them at all costs. So that's as far as prevention of patella fractures is concerned.
Thank you, Ronen. Thank you very much. Very lucid pointers regarding this difficult topic of extensor mechanism, inefficiency or fracture patella. Now we move on to the next important subject of fixation of the tibia, and none other than our convener, Dr. Rakesh Rajput, a famous surgeon from Kolkata, will speak on the single plate fixation for fracture tibia, periprosthetic fracture. Rakesh.
Yeah, I'll just go. Right. So I think I'll just start off with the patient's details. So it's a 60-year-old female, domestic fall. 4 years ago, she's had her TKR done. Comes with pain and swelling, active toe movements, and that's her medical status. She is quite a lot of diabetic road, I would say. And that was initially, there was a suspicion about fracture in the tibia, but when further x-rays were taken, it was actually proximal tibia just around the implant. So I think if you're looking at classification, then this is type 2, the classification of Helix. But if you're looking at the universal classification system, then this is through the bed of the implant, which is B1, then the bone stock is still good and the implant is still fixed. So it would be a B1 fracture. So I think there's no doubt about this that you require to fix them. The question we probably need to answer at the end of this talk and even John's talk is, when should you put a single plate and when should you put a double plate? And I think when we were growing up with these fractures, we were all putting single plates. But I would say that the trend now, at least for proximal tibia, is to probably add, even if it's a very small plate, to give a medial buttress also. So that's the way it's going. But we were quite happy when we put this plate on. And the other thing you need to do is to actually get your plate contoured to the bone and not the bone contoured to your plate. Because if you don't do that, then sometimes, you'll end up pulling the plate towards you, even with your clamps or something, and then the alignment might change. So you be very careful about your alignment. Keep looking at the C-arm, that your alignment has not changed. And then you will probably have a good result. So this was the type 2. This is another fracture I want to mention because this is an error we make at times. So if you just look very carefully on the x-rays on the right side and the left side, and you just see the flare of the proximal tibia. On the right side, we got a balance of this knee without actually doing. This is a vanguard knee, which has got a very thick fins. So on the left side, if you see that I had to do a reduction osteotomy, and the space between the fin and the actual outer cortex of medial tibia now is very small. So while trying to put in the trial, when we were doing the making the entry holes for the fins, the bone cracked there. So this is a very common type 1 fracture, which is generally on the table. And it's very easy to treat. You need to put one screw right from anterior to posterior, and then you can normally go on. Whether you put a stem or not is depending upon how much of a crack you've actually caused. So in this case, we didn't put in the stem. We did all right. So there are other cases where you have distal. So now that would be the C-type fracture in universal or the Felix type C. So these ones, again, you would debate, you want to put one plate or two plate. Most of us will be happy to put one plate, but have a very low threshold for putting in the second plate. And as I said, these days, we might actually end up putting second plate also. But in this case, that's okay to put one plate. Okay, so that's done. So next, the type 4, which we were talking about, the fourth type of Felix, which is the tibial tuberosity avulsion, predominantly as your compounding factor, apart from the proximal tibia itself. And so these fractures, when you do, you not only need to fix the tibia on the shaft, but you need to actually fix the tibial tuberosity also back to where. In these screws we actually use is the lag screw. So you need to put in and fix these fractures and lag your fragments. So very important to have this. These are not my cases, of course. Okay. So the other one is a fracture which we are now beginning to see because the UKR rates are rising. So here's a case which was a medial UKR done, looked fine. 4 years down the line, patient had a fall and boom. Now you have a whole condyle which is going. I think in the last IST meeting, there was a question asked by one of the audience that which is more difficult to revise, a UKR or a post-HTO patient. And I would say that if you have a UKR like this, it is definitely quite more difficult than probably most of the HTOs you will probably find. So these ones actually require full-blown revisions. And apart from that, they also require fixation of the fragments. So that's about it from my side. Thank you. So we can let probably John come in before we can discuss more.
Absolutely right. Yes.
John, ready? Or shall you want me to do this?
No, I've got it now, so I can do it.
Okay.
So I'll just share my screen. Hopefully, it's there. Okay, visible? Oh, sorry.
Right. Visible, audible.
This is the wrong one. Hang on. Yeah, that was the recording which I made.
Okay.
Okay.
Yes, it's visible.
Okay,
visible, John.
So I think we'll start with the case. This is a 78-year-old gentleman who had a total knee replacement done 2 years ago. He was diabetic, hypertensive, and not a very good medical candidate. But he ended up with a periprosthetic distal femur fracture 6 months ago, which we had treated, fixed with a DFLP, distal femur locking plate. And he was doing well when he fell again a couple of days before he came to us and had broken his proximal tibia. So his distal femur fixation looked okay. It was going on to heal satisfactorily, but this is what he had done to his proximal tibia. Okay, so now we have to decide. Obviously, it's a displaced fracture, which is not grossly displaced, but certainly a displaced fracture and involves both sides. So it's going to be unstable and we have to decide to fix it. So I think what are we going to learn at the end of the case? One is to assess the fracture and the patient. What investigations would you need? How would you plan your fixation and the counseling of patients and relatives? Because these periprosthetic fractures, just like hip fractures, have a certain amount of comorbidity, perioperative morbidity as well as mortality attached to it. And if you look at the mortality rates in periprosthetic fractures, they're actually quite high in the elderly. So you need to look at patient factors such as age, comorbidities, the bone quality. You need to mobilize, because these are elderly patients, you usually need to mobilize them early, and therefore you need to have secure fixation. And you need to look at the fracture factors because it is a periprosthetic proximal tibial fracture, so you have a short proximal segment. So the screw fixations may be limited by the implant. So that's another factor that you have to think of when you're fixing these in a B-type fracture, which is within the bed of the implant. You need to assess the implant stability. Obviously, we've had this discussion earlier about whether the implant is stable or not. And this is both from the preoperative radiographs, the preoperative CTs, as well as intraoperative assessment. And when you're doing just a lateral fixation, think about the cantilever forces which are still there, which might make the fixation not adequately stable to mobilize these patients. So in this particular patient, these are the CT scans which showed that the implant was quite stable. There was no evidence of any implant losing on the CTs. Of course, the CT is not going to clearly tell you, yes, this is stable, this is unstable. But if it's unstable, then you'll see lucent lines, etc., much clearer than you would see on the X-rays. So they're useful to get done in most of these situations. So we decided to fix this with a long lateral plate. We used a plate which allowed you polyaxial locking screws. So that helps you avoid the stem of the implant because that limits the amount of screws you can put proximally. Longish plate and then a buttress on the medial side. This is just a small plate which just you put a conventional screw onto this segment here so that this plate is pushed against the bone. You add 1 or 2 screws in the proximal fragment. So it's just working to buttress this fixation so that it's not going to drift into varus. And so this patient actually did reasonably well. He was mobilized with a walker on day 2. Weight bearing as tolerated. His dressings on the 3rd day were okay, and he was discharged by day 5. Sutures were removed at day 12, and he was doing quite well. Unfortunately, he didn't come for follow-up as he lived quite far away. So we tried to contact him for a follow-up, and his son, who answered the phone, said, well, he was doing well for about 6 months. He was able to walk without support by that time, but unfortunately passed away after 6 months of the surgery. So this is one of the things which make it important for you to counsel these patients in terms of the perioperative mortality as well. So this is something that you really need to think about. So where would I use a single? So this is a fracture which you can barely tell on the x-rays. The CT scans will reveal the fracture line here and maybe here. And it's a relatively involves one cortex only. And here we would fix it with a medial plate. So the C-arm images are showing you the fracture, as you can see, extending out here, but nothing on this side. And so we went ahead and fixed it with a single medial plate. Again, this plate allows you polyaxial screws, so you can avoid put in more screws into the proximal fragment. And this will then allow you to mobilize the patient straight away. You can argue that this fracture could be treated conservatively, but then it would mean something like a cast and keeping the knee protected from movement for some time. So the advantage of fixation in these is that you can mobilize them and get them up straight away. So I think what I would say for these fractures they are really a challenging problem. They're not as common as the periprosthetic distal femur fractures, but certainly they can happen intraoperatively or postoperatively, and they need to be assessed very carefully in terms of the general condition of the patient, the stability of the prosthesis, and the quality of the bone all need to be considered before you plan your fixation. And because they are mostly elderly patients, they need to be mobilized quickly, and therefore double plating in most of these displaced fractures or complete fractures would provide better stability to allow you early mobilization in these patients. Nailing is possible, but for most of these proximal or B-type fractures, it's still not something that most of us would do. Thank you.
Thank you so much.
Sure.
I think it was a very, very, very nice presentation. And I'm sure that during the discussion, the question will come out that which approaches and the two plates, how to fix them well without compromising the soft tissues. So I think that we'll have a discussion, Rakesh, after Dr. Sen's talk.
Yeah, I think let Dr. Sen also speak. It's getting quite late where he's...
Yeah, we'll invite Dr. Ramesh Sen, the immediate past president of the Indian Orthopedic Association, to speak on periprosthetic fracture in both tibia and the femur.
Thank you for giving. My only submission is that the internet here is not very good, so there could be a problem in between. So I'll get excuse for that. So I'm talking about a periprosthetic situation. And when you look at as Abhay told in the start, the incidence of these cases for distal femur up to 2.5, while it's much less common in tibia and even less common for patella. And when you look at all those classifications, which I mentioned in the start also, there are a lot many. And now what is most important for a situation is this unified classification system, where think about the type E. This type E, according to this classification paper, is one which involves at least 2 bones supporting one arthroplasty, which could be any kind of a combination of femur, tibia, femur, patella, patella, tibia, or theoretically all 3 also. That considering each bone in isolation is again recommended. I mean, that is a conclusion they have drawn. So I'm putting up a picture of a lady, 64 years, from UK, a tourist. She had a surgery done in 2004 for rheumatoid arthritis.
there was a twisting slip in the bathroom. She was admitted in a local hospital and 3 days later was shifted to our hospital. Now, if you look at the scenario over here, if you again coming back to the same classification type E, where it is written that you have to manage with block.
I think we've lost Dr. Sen. So, Dr. Sen, I think your internet is a bit weak.
Yeah.
So you want to switch off your video?
I can switch off, but I'm doing it.
Yeah, that's
is
okay
that
now.
Audible now?
That's okay. Audible, yes.
Yeah. So this is a block cut analysis. When you look at the femur, the total component was loose, and when you look at the tibia also, the total tibial component was quite gone at the type B type of a fracture over there. So, sorry. Now this is the detailed. Here you can see the kind of a combination with the tibia that it has involved within the joint itself, within the prosthesis itself also. In the tibia also you can see the kind of a combination it was there. I'll show you the, so we had an option that we could better in this kind of a situation go for a replacement rather than trying for osteosynthesis. Now there is a little blockout analysis, there is a little difference from that kind of a thing. Even if the tibia is not bad and the femur is bad, still we will have to go for replacement, even if tibia would have been good. But here tibia was also bad. So this was the situation when we opened it up. Femur was definitely bad, and tibia anteriorly also tibial, this was avulsed out. So this is what I have taken it out, and the tibial was intact with the proximal fragment, but anteriorly all the fragments from the tibial side were also broken out, except for the plate was well fixed, but other fragments were out. So we had to take it out both. So we took it out, debrided the area from all these things, and subsequently planned for this hinge implant, the trials there, and subsequently moderate rotating hinge knee. We had, this is again the trialing done, and this is the implant which we used over there, because there was a tibial Debabrata avulsion also, and this is subsequently the modular hinge going to the prosthesis. And tibial Debabrata, that big fragment has also to be reattached with, and it was sutured around the sleeve which was there, and that is the suturing. And this was the change from a comminuted distal femur and a proximal tibia to a hinge, a rotating hinge over there. This is the subsequent follow-up X-rays. This is after the suture removal, things were okay. She was mobilized. This is after 12 weeks of surgery. She had reasonably good range of movement up till 90 degrees, 0 degree to 90 degrees. She was quite active. And then you can see she's able to put weight. And if you can see, this is after 12 weeks of surgery. She was more excited to go around, as well as you can see the kind of a movement she was doing at 12 weeks. We can say she was more active than what we had anticipated. Then if you can see over here, she actually went to Bristol, where she belonged to, and I had given the reference of Dr. Mehul also, so probably went, but in between, while after about a year and a half, she sent us a video how she's doing, that she's comfortable, she's walking around after another 2 years of the surgery, and she was quite okay. Later on, we knew that she had a problem. Anyway, I'll talk this thing. So if you look at the literature, so these are the cases. This is one of the case report published in the literature. But this is a bilateral fracture of both the sides, both the tibia and femur. But the diaphyseal, the tibia is on the diaphyseal sides, and the femur fractures are also not involving the joint. So both sides, they have done the synthesis only. And this is the another report again involving not the area around, but the type C for the tibia also, and likewise the femur also, it is not involving the joint. I had been through one of the reports where this kind of a replacement has been done, but I could not get that reference. Anyway, whether you are doing a double plate fixation or we are replacing a distal femoral replacement, this study of this year itself says there is hardly any difference in either post-operative complication, reoperation, or an operative time. This another paper, which was about 10 years back, which says revision total knee arthroplasty is a reconstructive solution for these difficult problems. And judicious use of adequate constraint level, sleeves, and intramedullary stem can solve the problem of stability, bone loss, and alignment, and this can successfully address. And this is the kind of a conclusion that we have to define a reasonable and a correct procedure as the main principle. Revision surgery of the knee for the periprosthetic fracture with a proper prosthetic selection can attain a good outcome. And the applicability of a revision TKA is constructive solution for prosthetic knee fractures, and it is highly recommended. Thank you.
Thank you so much, Dr. Sen. Rakesh, before we have a discussion on this important subject of periprosthetic fracture, especially the tibial fixation, and what Dr. Sen has talked about, one important topic that we are probably needs to be discussed in brief, the peroperative fractures and what is to be done. If you allow me, I'll just put up the 3 slides, which will clear up many things for our younger colleagues. Rakesh?
Yeah, Rajeev, go ahead. Yeah, go ahead.
Okay. Now that is one subject which is very, very important. Can you see, Rakesh?
Okay, we can, yeah.
Now, this unicondylar peroperative, we could see that while hammering the tibia, there was a incomplete fracture. And immediately this fixation was done for this patient. And that's what we see this patient at 1 year. And she is doing very well at a follow-up of 7 years today. Another peroperative fracture, we can see that middle condyle of the femur fixed with the cannulated screws. And that's what we see the follow-up of 8 years. And the last slide, this patient who had a rheumatoid fixed flexion deformity, fixed with the screws, peroperative fracture, that's what we see this patient at 9 years. So peroperative fracture, if we see, friends, it is very important that we deal with this. We first is the identify it on the table before we close the wound. And if you have a suspicion, CIAM is a very good tool. And if there is a reason to suspect that there is a fracture, probably fixation with the screws minimum is very important. Yeah. Thank you so much. Rakesh, we can have a discussion now.
Yeah, I think Rajeev, you showed some very good cases, and I think condyle fractures are not. Yeah, Rajeev, sorry, Ronen. Yes.
Rakesh, before you guys go ahead, I'd just like to mention before everyone leaves that this is our 34th webinar, and all our 33 webinars are actually up on YouTube as well as on our website. And as you can see, that each topic is discussed in detail. So especially from our friends from the IOA who have joined for the first time, I would really request you to see these videos because I'm sure you'll find them very helpful in your day-to-day practice. That's all I really wanted to say.
Thank you, Ronen.
Ronen, at the same time, it is important to request them that they should become the members of Indian Arthroplasty as well.
That goes without saying.
Go ahead.
Can I make a point, sir?
Yes, Abhay.
Yes, Abhay.
So, as far as fixation for these situations are concerned, whether it is just a supracondylar femur or a tibia or both or a patella in conjunction or isolated, I think the take home that we need to give our colleagues here is that, just plates are very often needed where fractures are fixable and where the configurations demand for a fixation. And just probably using screws alone probably does not do the job for us well, because once there is an obliquity to the fracture, the shear forces acting and going through the condyles is so high that the propensity for it to displace and cause a secondary displacement, a secondary deformity, and basically a loosening and wear of the liner is much higher. So I think we should give a message that probably where needed, it's nice to use a plate to buttress the fixation, even if we can lag those fractures with them in a minimally invasive fashion.
Yeah, and
very right, Abhay, that plate should be available on the table for all arthroplasty surgeons. So, John, I'll ask one question to you. You talked about the dual plate fixation for tibia. Now, upper leg is an area which is the soft tissue management is really difficult after the bulky plate fixation. So what do you suggest? What approach do you take for dual plate? Do you take one approach or two approaches?
So you are actually, so these approaches are basically minimally invasive. Of course, you would need to visualize the proximal part of the fracture because there your screws need to be sort of placed very accurately to avoid the stems, etc. But the distal part, you just slide in the plate in a submuscular extraperiosteal plane, okay? And you put in your screws. And again, the medial buttress plate is again done through very small incisions. So you're actually not disturbing the soft tissue. You're minimally disturbing the soft tissue. Of course, if you have a lot of swelling, we have had that issue with one patient where the patient came with a lot of swelling. I think just like in a proximal tibia, there you have to wait for the swelling to subside. Okay, but they are rare in the periprosthetic fractures because usually they are low energy fractures. But if you have a high energy periprosthetic proximal tibial fracture for whatever reason, in a car accident or something like that, then that swelling becomes important to wait for swelling to settle down. You may have to span the injury or at least keep it in a slab till the swelling comes down before you try to do plate fixations.
Yeah, but most of these fractures are low energy trauma.
Yeah, most of them. So you don't have a lot of...
Rakesh, please.
Yeah, I was saying that there are two things here. One, it is not the same as distal femur where you have a big incision in the distal femur and when you go on the side, the skin chances may be less. Whereas in proximal tibia, the extension below the knee is very small part of incision. So when you give even 2 incisions on the 2 sides for dual plating, it doesn't cause too much of issues. Number 2, I think we moved away from 4.5 to 3.5 plate systems. And that really doesn't occupy much of the footprints on the proximal bone. So I think that also helps a lot.
And these plates are actually quite strong. The newer generation,
quite strong plates.
3.5 millimeters, the 3.5 millimeters are actually very strong.
Strong and low profile.
Yeah.
3.5 strong, low profile. So all these things are there.
Can I make 2 very quick comments? Yeah. So one so one already discussed that low profile implants are very, very good, as both Rakesh and John have pointed out. The other thing important is that if we have a post-operative low energy trauma in an elderly, it is very important to also assess sometimes the fracture may be a effect rather than a...
You're losing your Abhay.
Abhay, we lost you.
I think what you're saying is
any more question in the meantime?
I think he was probably trying to say that it may be a sign that the prosthesis is loose. And of course, that is something you have to assess before you fix the structures.
Yes. So,
yes, Abhay.
Am I audible now?
Yeah, you are.
Yeah, so that's exactly what John has hit the nail on the head. So very often in post-op situations, low energy trauma, one has to assess that, the fracture may be an effect rather than the cause. And one has to actually very carefully assess if the prosthesis is already loose and the fall may be a result of that loosening, and it might actually need a revision rather than fixation for an innocuous looking fracture.
Sure.
A very important point, Abhay. And also the unstable knee. Probably one should very carefully see that the knee is unstable, because unstable knee is also a very important reason because of which the patient can have a fall. Thank you so much, all of you. If there is no other question, we'll close this webinar in time. Rakesh?
Yeah, I think just a take-home messages, which Abhay already has said. So last take-home message, I think Dr. Sain's talk was very important for that, were that the results of fixation and replacements in those cases was not too difficult. And I think the reason is because even if you have a doubtful loosening, if you fix them well, they normally do well. And that's why if you have good chances that the implant is fixed or doubtful that it is loose, go ahead and fix this first. Only if it is blatantly loose, that go ahead and actually replace that. So I think that's the message we should give everybody. In doubtful cases, if you're fixing, then probably a dual mode fixation should be done, and not just a single mode reliable. And of course, we've given examples of other reasons for why to put dual plating.
Thank you so much, Rakesh. I think it's a very, very well given message
and
to our younger colleagues.
Just one advantage of that approach is that if you're able to fix the fracture, you may be, even if the prosthesis is loose, you may be able to revise it with
simple revision,
relatively smaller prosthesis.
Smaller revision, absolutely. That's the whole reason we do that.
After the union of the fracture. You're very right. Yes. Thank you so much, everyone, especially the faculty and participants. I'm sure that this topic, which is partly belonging to the trauma surgeons and partly to arthroplasty, but nevertheless, it's a very, very important subject because post-replacement, post-arthroplasty fractures are real nightmares, and being the serious surgeons, we must look after it very well. Thank you so much, everyone. Rakesh, Ronen, if you have to say anything, please.
No, I think the webinar.
Close.
I'd just like to say that, as we mentioned, that those of you who are not members, you can go onto our website and become members online. And I'd like to thank everyone for a very lively discussion and for sticking to time. So thank you all very much, and we look forward to more joint webinars in the future. Thank you, everyone.
Bye.
Thank you, Ronen. Thank you, Rakesh. Thank you, everyone. Thank you. I'll just close the